Hi, I'm Rosemary Clee, the Executive Director for the Bergen New Bridge Medical Center Foundation, New Jersey's largest not-for-profit hospital, and the sponsor of In the Know It Row, an informative conversation about important health topics. Today, I'm joined by Dr. Abbasi. She is a board certified by the American Board in Internal Medicine with nephrology board certification as well. She gained her fellowship in nephrology at Rutgers University Hospital and now is practicing at Bergen New Bridge Medical Center. Examples of disorders Dr. Abbasi manages include, but are not limited to, kidney disease, hypertension, kidney stone prevention, kidney transplantation, electrolyte disorders, and dialysis. Hi, Dr. Abbasi, how are you?
Good, how are you, Rosemary?
Good, good. Can you tell us about the kidneys and what they do?
Well, I think it's very important to know what the kidneys do before we can understand what kidney disease is. So we have two kidneys. They're bean-shaped organs. They're located on the right and the left side of the spine, right underneath the rib cage, and they consist of millions of filtering units. There are some people that are born with one kidney. Some have had it removed surgically because of cancer or stones, and there are some people who have donated one of their two kidneys and they live normal lives. Kidneys play a couple of important roles in our body. They are important in maintaining fluid balance in our body by excreting excess water in the urine. They regulate the concentration of electrolytes and minerals in our blood by excreting excess amounts in the urine. They remove toxins and waste products such as urea in the urine. They also produce some hormones that regulate blood pressure, red blood cell production, and promote bone health.
What is the difference between acute versus chronic kidney disease?
So kidney disease is the ninth leading cause of death in the United States. It's divided into acute versus chronic disease based on duration. And it's because of damage to those filtering units inside the kidneys that eventually leads to kidney disease.
And what's the difference between acute versus?
The difference, so acute kidney injury would be basically, it's a sudden decline in kidney function. Okay, and it's usually reversible if it is detected early and interventions are taken to manage it. It could be due to poor blood flow to the kidneys, which could be due to reduced volume. Example would be inadequate oral fluid intake, would be GI losses such as vomiting or diarrhea, or excess use of diuretics, which excrete water from our body. Very high or very low blood pressures can also cause acute kidney injury, because they lead to poor perfusion of the kidneys, which leads to, again, poor oxygen delivery to the kidneys. Examples would be dehydration, hemorrhage, liver failure, heart failure, where the heart is not pumping enough blood to the kidneys, stroke, heart attack, sepsis are secondary from it. Direct damage to the kidneys by infections, by toxins, and even prescription medications can cause acute kidney injury. Examples would include NSAIDs, certain antibiotics, contrast dye that we use for CAT scans and cardiac catheterizations, alcohol and illicit drugs. Obstruction can lead to acute kidney injury. Because the urine backs up into the kidneys and causes swelling of the kidneys. It could be due to kidney stones. It could be due to enlarged prostate, which, where you cannot empty your bladder out completely. And it can be due to mechanical obstruction or compression from tumors. Chronic kidney disease is when the kidneys have not been working well for greater than 3 months. And it's usually a progressive disease that declines over time, and it's usually not reversible. Chronic kidney disease is divided into 5 stages based on GFR. GFR is the glomerular filtration rate. It's basically, it's a good measure of kidney function. It's almost like a percentage of how much your kidneys are working. It's a math formula that takes into account your age, your gender, your ethnicity, and your serum creatinine, which is checked on blood work. So CKD stage 1 is when your GFR is greater than 90 and your kidney function is pretty much normal around this time. CKD stage 2 is mild chronic kidney disease. with a GFR of 60 to 89. CKD stage 3 is moderate chronic kidney disease with a GFR of 30 to 59. Around this time, primary care physicians usually refer their patients over to nephrologists for further management. CKD stage 4 is severe CKD, and the GFR is between 15 and 29. Around this time, patients will complain of volume overload because they're unable to excrete the excess water in their urine, and they can get higher blood pressures. They can have electrolyte abnormalities, especially with potassium, calcium, phosphorus, and bicarbonate. They can develop hormonal imbalance, which can lead to anemia and poor bone health. Dialysis education starts around this time, and we start talking about transplant options too. CKD stage 5 is end-stage renal disease, and it's when your GFR is less than 15. And by this time, patients are either on dialysis or awaiting to be on dialysis.
So what are some of the risk factors, doctor, for CKD?
Well, there are modifiable and there are non-modifiable risk factors, like with any disease. The modifiable risk factors would be obesity, smoking, alcohol use, poor blood pressure control and sugar control, especially if the chronic kidney disease is related to high blood pressure and diabetes. And this is usually due to non-compliance with medications or a diet that is high in sodium and carbohydrates. Excessive use of NSAIDs or prolonged use of NSAIDs can also be a risk factor. Non-modifiable risk factors would include older age, ethnicity, and family history of kidney disease.
Can you tell me what causes CKD?
So the two main causes of chronic kidney disease are diabetes and high blood pressure, which account for about 2/3 of cases of chronic kidney disease. Diabetic chronic kidney disease is also accompanied with protein in the urine. And sometimes we tend to see that even before the decline in kidney function. And it's usually a herald sign, to start paying attention to the kidneys when we start seeing the protein. Diabetes and blood pressure control remain the mainstay treatment for these diseases, okay? Use of ACE inhibitors and ARB, which are a class of blood pressure medications, are helpful because they reduce the spilling of protein in the urine. The third leading cause of chronic kidney disease is glomerulonephritis, and it is due to damage to the filtering units inside our kidneys. And this damage could be due to autoimmune diseases such as lupus, inflammatory conditions due to viral illnesses such as HIV, Hep B, Hep C. Some of these glomerulonephritis diseases are inherited. Some are secondary to high blood pressure, infection, or malignancy, and some are idiopathic where we don't even know the clear trigger, what triggers these diseases. And these, they're divided further into the nephrotic diseases in which you see protein in the urine, and the nephritic diseases in which you see microscopic blood in the urine with or without protein. The disease ranges from either having a benign course and never requiring treatment to a very aggressive course where they rapidly progress to dialysis. Some of these diseases are readily treated with medications, and some are very resistant to treatment. Treatment options include conservative therapy with ACE inhibitor, ARB, statins, and fish oil. They can include, then we move on to steroid courses, and we have immunosuppressive agents with or without steroids to help treat these diseases. An inherited chronic kidney disease is polycystic kidney disease, which is, patients usually will have a family history of this disease. In this disease, you get large cysts that enlarge over time, and they start damaging the surrounding kidney tissue. Tolvaptan has been approved to slow down the progression of polycystic kidney disease. Acute kidney injury of any cause can lead to chronic kidney disease if it persists for greater than 3 months also.
So how do you diagnose CKD?
Well, you start off with a blood test, okay? The blood test can tell you how well your kidney function is. It can tell you your serum creatinine and your GFR. The normal serum creatinine is basically less than around 1.0, and it's dependent on muscle mass. So people who have a low muscle mass like me tend to have a serum creatinine on the lower end of normal. People who have a higher muscle mass, like people who do bodybuilding or weightlifting, tend to have a creatinine on the higher end of normal, or even a little above normal. And the blood work can also tell you your GFR that's already calculated in there based on your race. Blood work can tell you if you have any electrolyte abnormalities as well, and whether they are within normal range or not. Imaging is always helpful, with a CAT scan or renal ultrasound. They can tell you if you have any kidney stones and if they're causing any blockage. They can tell you of any anatomical defects. They can tell you kidney size. Small shrunken kidneys are usually indicative of long-standing chronic kidney disease. They can also pick up on stones and cysts as well. Sometimes we need a renal biopsy for a definitive diagnosis. Before we do a renal biopsy, we tend to check for autoimmune and inflammatory markers and viral illnesses, so the pathologist kind of has a little idea of what we might be looking for. The indications for a renal biopsy would include when the diagnosis is not straightforward. It would unexplained heavy protein in the urine, presence of microscopic blood in the urine, rapid decline in kidney function, or if you have a transplant kidney that's not doing well, renal biopsy is definitely indicated. So those would be some ways to kind of start off your diagnosis of kidney disease. And it holds true for both acute and chronic.
So what are the symptoms? Some of the symptoms that I should look for if for CKD or, the chronic kidney disease?
So patients with mild to moderate chronic kidney disease may have no symptoms, okay? Symptoms usually occur if you have like a stone or an infection. But as CKD progresses, patients can start seeing fluid overload, okay? Which will raise their blood pressure. They will start seeing swelling in their legs. Some will become short of breath if the fluid builds up in the lungs. We kind of treat that with diuretics, which kind of help push the fluid out, while they're buying time off dialysis. Patients with severe CKD and end-stage renal disease can have electrolyte abnormalities and a hormonal imbalance. High potassium is something we look for because it can cause irregular heart rhythms. It can even cause cardiac arrest. There are medications out there that can lower your potassium. High phosphorus, low calcium, along with low vitamin D levels, and acidosis in the body can, promote poor bone health. And we have medications that can bind phosphate and excrete it from the gut. We have medications that can raise the calcium. We have medications to treat the acidosis as well, like, baking soda equivalents. Anemia can result from not enough production from erythropoietin, which is a hormone that is normally produced by the kidney. So in these patients, we can give them, epogen injections to kind of help with the anemia. As CKD progresses to end-stage renal disease, patients will complain of symptoms that occur because of the buildup of toxins such as urea. These would include fatigue, confusion, increased somnolence. Some patients will have insomnia, trouble concentrating, poor appetite, weight loss, nausea and vomiting, itching, and rash and tremors would also be some of these uremic symptoms.
And so what is some of the how do you slow down the progression of CKD and promote kidney health?
Okay, I think that's a great question because that's where we spend a lot of time with our patients talking about how to slow down the progression. You have it, now what are we going to do about it? So I tend to spend a lot of time because I feel like as the patients understand, the things that they can do to slow down the progression, they are more compliant and, they'll show up too. So blood pressure and sugar control are very important to slow down the decline of chronic kidney disease that is secondary from diabetes and high blood pressure. The blood pressure goal for patients with chronic kidney disease is less than 130/80. The hemoglobin A1C goal is less than 7.0. Using ACE inhibitors and ARBs are very important in patients who are spilling protein in their urine. The goal urine albumin to urine creatinine ratio is less than 30 milligrams a day. But patients with diabetes can spill much more than that. Okay, ACE inhibitors and ARBs should not be used in patients who have advanced chronic kidney disease. They should not be used in patients who have high or borderline high potassium. NSAIDs should be avoided in patients who are taking ACE inhibitors and ARBs. Routine follow-up with physician with routine labs is also very important because early detection of any rapid decline in kidney function allows physicians to take interventions such as adjusting medications and diet, which can help recover some kidney function. I have sometimes patients who will not show up for a long time, and then by the time they do show up, their kidney function is pretty bad. Lifestyle changes such as eating healthy, exercising, quitting smoking, avoiding excess alcohol, and compliance with medications is always very helpful. Avoiding conditions that can hurt kidneys, such as dehydration, recurrent kidney stones, kidney infections is always good. Avoiding any exposures and taking caution when using NSAIDs and certain antibiotics, herbal supplements and contrast dyes can be very important. Usually I always ask my patients, in addition to the prescription medications, have you taken any herbal supplements? Have you had any IV contrast lately? If I see any sudden decline in their kidney function.
So you mentioned something about routine. What's the normal routine? If I was diagnosed with an acute or a CKD, what does that look like as far as a healthy way to promote kidney health? I've been diagnosed, and now I want to make sure that it doesn't progress to a stage 5.
Okay, so acute kidney injury, we tend to bring them in sooner. Okay, we definitely go over any acute factors that could have caused it. I will ask them about their hydration status. Are you hydrated enough? Have you been on any recent antibiotics? Are you taking any NSAIDs? How has your blood pressure been? I'll look at their list of medications, and sometimes if they're on a diuretic, I will take them off of it, as it can cause, volume depletion and dehydration. If they're on an ACE inhibitor and ARB, I will also take them off, which is an indication. If you have any acute kidney injury, you take it off and see how your kidneys. And I'll bring them back maybe in, like, depending on how severe it is, I'll bring them back. If it's very severe, I'll bring them back in 2 weeks. If it's not that severe, I'll bring them back in 4 weeks. I might do an ultrasound in the middle to see how. If there's anything else we're missing, like stones, or I'll check a urinalysis and make sure there's no infection in there. We can always check other markers, like inflammatory markers, to see if there's anything else. And if it's a chronic kidney disease patient and they have an established chronic kidney disease diagnosis, I usually see them every 3 months. But if they have a rapid decline somewhere in the middle, I'll bring them in maybe in like 4 to 6 weeks, just to make sure the changes we made, did it cause any recovery in the kidney function? Or if it didn't, is it just a progressive decline? In our visits for chronic kidney disease patients who have diabetes and high blood pressure, we go over the goals, compliance with medications, diet control. We talk about all that.
So a rapid decline, what does that look like? I mean, there's red flags, I'm assuming, correct?
A rapid decline is when your creatinine is doubling, or the GFR is dropping very fast, more than you expected to. You look for triggering factors again. If it's very rapid and you're getting concerned that there's something else that may be happening or you're missing, you can always do imaging tests. You can do a biopsy, which can give you a lot of information as well. Sometimes patients who have high blood pressure or chronic kidney disease will rapidly decline, especially if they have had periods of non-compliance, or they have not been taking care of themselves, or not following up with doctors. That is common to see in chronic kidney disease. But if you have a patient who's normal and has a decline in kidney function, You, like I said, look for triggering factors, you do the appropriate lab test, imaging, a biopsy if needed, and you bring them in sooner than later.
So promoting a good diet, what does that look like? What's a good diet for kidney health?
So a good diet would be a diet that's low in sodium, okay, for people who have high blood pressure. For diabetes, it would be a diet that's low in carbs, okay? Because remember, as blood pressure and diabetes is not controlled, your chronic kidney disease may worsen faster. Um, Patients who are near dialysis, okay, but not on dialysis, we recommend a low protein diet so they produce less toxins such as urea. We promote a diet that's low in phosphorus. Because their kidneys are unable to excrete the excess phosphorus. We promote a diet that's low in potassium, because they're unable to, again, excrete the potassium. So they're on much more restrictions. And despite dietary restrictions, we get patients all the time who will have high phosphorus and high potassium who are nearing dialysis, but not on dialysis yet. And for them, there are medications like phosphorus binders or potassium binding agents that we can use to kind of buy time until they get on dialysis. And once they do get on dialysis, the diet is more restricted to a fluid restricted diet. So then we ask the patients not to drink more than a liter a day because their kidneys are not really making any urine at this point. We tell them to remain on a low phosphorus and a low potassium diet, but they can now increase the protein in their diet because nutrition is very important. And it has a mortality benefit in patients who are on dialysis if they have an adequate nutritional status.
So is there any relationship between kidney disease and COVID-19?
Well, it's a new virus and the research is still ongoing. Patients who have chronic kidney disease and other chronic medical conditions develop severe illness if they do get COVID-19. Patients who are on dialysis and are kidney transplant recipients are already immunosuppressed. So they are at higher risk for getting severe illness with COVID-19. Patients who are on dialysis, we tell them to continue with dialysis. Patients who are renal transplant recipients, we tell them to continue the immunosuppressive agents. We just tell them to, practice, social distancing, wearing mask, hand hygiene. If they have any symptoms, contact their doctor, or go to the nearest hospital if they're not feeling well. There have been cases of COVID-19 related acute kidney injury in patients hospitalized with COVID-19. The acute kidney injury has been thought to be secondary from sepsis, from inflammatory, and from the inflammation from COVID-19, from increased blood clotting and direct damage to the kidneys by the virus itself. Most of the patients with COVID-19 related acute kidney injury who have recovered never fully regained complete kidney function. So there are some cases like that. And some cases that got COVID-19 and ended up on dialysis. So we've seen the whole spectrum.
Wow. Okay. Well, thank you, doctor, and everyone who tuned in. And if you'd like more information about our services or to visit with Dr. Abbasi, please visit newbridgehealth.org. And to support our foundation, please visit newbridgehealth.org. And if you'd like to make an appointment, you can call us at 201-225-7130. And thank you so much. Thanks for joining us today.
Thank you, Rosemary.
Take care.
You too.